our Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I think we didn't do the Pledge of Allegiance.
To do it again.
Make sure you keep that off, so it's not a good headache.
Okay. So that'll start out our Board of Directors work session. And that'll move us to item number 2, roll call.
Oh, that's me. Nick is not no longer.
Wow.
Yeah.
Nice.
How did I not do that one? Okay, let's try this. Zach,
Yes.
Tom,
Yes.
Joe,
Yes.
Audra. Yes. Lynette.
Yes.
Thank you. There. We're all here.
That'll move us on to item number 3, adopt the agenda.
What agenda?
Specifically the
session.
work session agenda.
Just the work session?
Yeah.
Okay.
So technically work sessions, you don't have, I mean, you still have an agenda, but there shouldn't be like motions or anything along those
No.
lines, no official action taken. So even for adoption of the agenda, unless you have something that says otherwise, you don't really have to.
It's true. It's
And there
also-
shouldn't have to be minutes of it,
Right, okay.
so.
No, I appreciate that. So then item number 4, TAD operations.
So I just wanted to do a quick PowerPoint, and then we can go into questions, or, well, I guess it's not gonna be quick. There's a lot of information on it. But just to kind of show who we are, what we do, and hopefully that answers some of the questions, and if not, then we can just continue from that point. So, and I kind of wish I would have done this with previous boards, because I think this is kind of a cool idea to kind of show kind of who we are. It's,
Can you see okay, Audra?
Mhm.
Okay.
so, welcome to Trinidad Ambulance District. We're a special district. We provide EMS for the majority of Los Alamos County. We cover everything except for the Kim Area School District. We provide mutual aid and secondary response to that area. They're covered by the Kim Volunteer Fire Department. And they run about 12 calls a year roughly. They're about 60-minute response time for us. So that's why they cover their own area. They've opted out of our district. So we provide 911, interfacility, secure transport, standbys, just basic EMS type services. We're focused on rural healthcare and high quality patient care. So our mission is to deliver compassionate, reliable, and high quality EMS care. Our vision is to lead rural EMS innovation while preserving community trust. And some of our core values are safety, integrity, professionalism, and community innovation. We have 2 ALS ambulances staffed 24/7, 365, and an on-call crew. The on-call crew can be ALS or BLS, and they're usually coming off of their 48-hour shift. They're on call for 24 hours, and they get paid during that entire time.
Can I pause just a second?
Yeah.
Just for people that are watching, listening, whatever, what's the difference between ALS and BLS?
So ALS is advanced life support. That's usually an EMT, intermediate, or paramedic. BLS is basic life support, and that's it could be an EMR and an EMT. You have to have an EMT to transport, or 2 EMTs. And just the difference is some of the procedures they can do. So advanced life support, they can intubate, they can do cracks, needle decompression, some of that kind of stuff. Whereas the EMTs are more basic, real basic suctioning, real basic airways. They can't intubate, they can't push certain drugs, they can't push narcotics, that kind of thing.
So are most of our staff here, are they ALS?
We're about 50-50.
Okay.
About 50% are ALS and 50% are BLS.
Okay.
And I'm sorry, to say again, to transport, you have to have what?
Yeah, to transport, you have to have an EMT attending the patient. The other person can be a driver, it can be an EMR, it can be, just depends.
It doesn't have to be a
Agency.
paramedic.
No.
Okay. Okay.
We
It just, I would throw in, it just depends on the level of care of the
Sure.
patient, but that's
Most of our crews though are,
all of our crews are one BLS, one ALS, except for the on-call. We cover roughly 100 miles of two-lane highway and 40 miles of I-25. We partner with local volunteer fire districts for quick response teams. So we provide them with training, with equipment, jump bags. Some of the fire districts that have space, we provide them with an ambulance or a quick response vehicle. So they can respond as a first responder prior to us getting there, just because we cover such a large area. And obviously, we're based right here in Trinidad. So programs and innovations that we're looking at: mobile integrated health / community paramedic, telehealth to include behavioral health and behavioral telehealth. We're looking to bring whole blood to the rural community. We're already doing the Narcan distribution in.
Okay, stop you there again too. What, again, I know Zach knows this stuff, but for those of us, what does it mean to bring whole blood?
Whole blood, so in parts of the state right now, they're doing a pilot program. The EMS agencies are carrying whole blood, usually packed red blood cells.
And yeah, so it's whole blood as opposed to blood products like plasma or things like that.
So rather than starting an IV with just normal saline salt water, now some agencies are able to take blood straight to the scene and they can start infusing blood immediately for some of those trauma patients that need it.
And with a hemorrhage, that's the only thing that's going to fix a hemorrhage besides surgery is more blood. And right now, historically, the only thing that EMS has been really allowed to use is normal saline or what's called lactated ringers, and neither of those are capable of carrying oxygen. So while you may be able to increase their blood pressure a good amount and be able to help them in that way, it also dilutes their blood quite a bit and can help prevent them from getting any better. So having whole blood is absolutely, it's something that when you're dealing with major traumas or any kind of major blood loss, that's typically the only thing besides a surgery that's ever going to fix what's going on or stem what's going on.
Okay, I just, for people, again, watching. Right?
No, I appreciate it.
No, I think
Yeah.
I think you're very right. That some of it is kind of jargony,
Yeah,
for sure.
but I'm sorry, one more question. So it's type O, right? Because that's
Type
the
O
only
negative.
that's universal.
Yeah, type O negative because it doesn't have the rhesus factor and I forget the proteins or the antigens but type O negative is the universal donor.
Okay.
And so is that program already in place and you already have a supply of whole blood?
No, we're trying to figure out how to get it here. The biggest part, or the biggest roadblock, I guess, for lack of a better term, is waste. And so
It has a shelf life.
yeah, we have to be able to rotate it with a trauma center that can use it within a certain amount of time. And so for rural USA, they're worried about waste, and we don't want to waste blood because it's so hard to come by. And so we're trying to figure out how we can get it into a rotation somehow, somewhere, that it doesn't go to waste.
And to kind of answer, I think a flip side of your context was it's a pretty groundbreaking thing for EMS to be. Usually the only thing in the emergency field that really, besides a hospital that carries blood, is occasionally helicopters will have one bag. And so it's a huge thing. It's a very good thing for care, and it's absolutely a groundbreaking thing that somewhere like us out in rural America is able to try and look at it.
So what is like the shelf life, for lack of a better term?
It depends on who you partner with, who supplies the blood, but it's usually a week to 2 weeks, and then they want you to rotate it, and once you get it back, you have to use it fairly quickly. So they want you to be close to a level 1 trauma center because they're the ones that are more likely going to use it in that time frame.
Does Pueblo have level 1 trans?
Denver's the closest
Oh.
level.
I thought
Springs have
Yeah,
Springs has it.
Springs has it.
Memorial Central's at level 1.
Yeah.
So how, they don't put it in you know, the post office, how do they, is it a special shipment?
I think it's usually blood couriers.
Yeah, yep. It'll have to be shipped cold through a blood courier, and we'll have to store it here in a refrigerator. And then, like I said, after a certain amount of time, we'll have to ship it back the same way.
So in previous experience, in a year's time for, as an example, how often would you have been able to use?
You know, it's hard to say. I would guess probably a dozen times or so, but they're starting to do studies now that they're using it in OB patients, they're using it for GI patients, and Springs is on a pilot program, and they've given somewhere upwards of 50 doses already in a matter of probably 6 months. So they're seeing that it's more beneficial and that the need is kind of there. And so you can kind of expand a little bit more than just trauma. And so we would be able to probably use it a little bit more than that, I'm guessing.
And it would be an EMT that could give it? Not
No,
Be a
paramedic.
paramedic level.
Yeah, paramedic has to.
I guess I'm
has to be
sorry, I'm still confused on what's the rank?
Paramedic.
So
EMR.
Yeah, and
Paramedic is at the
Is a
top.
medic,
Yeah.
you know, yeah.
Okay,
with a decent rule of thumb is most cardiac things are going to be under the control of a paramedic or ultimately require a paramedic. And so if you're dealing with whole blood products, then that's going to be, you know, directly cardiac, directly brain, or it's just, that's an easy way to kind of remember it, as most of the cardiac duties are dealt to a paramedic. That's
Okay.
a lot of their training is to do with cardiac stuff.
okay, that helps, okay.
And for chain of custody, would they not allow you to transport it yourself back to Springs at some point? Say, for instance, I mean, you get a call, you know you're gonna go, could you do that, or they won't do that for?
Yeah, more than likely they would. Like I said, you just have to
Working
have
out the
a special
details.
refrigerator to keep it at a certain temperature.
I assume you would have to have a contingency plan too, in case for some reason you don't end up going to Springs within that time frame. Or it's like, say, like you, for a week's time or something, or a week and a half, you only write calls that end up needing to be transported to Pueblo.
Yeah,
And then
we-
it's like, you'd have to have some kind of contingency plan.
We'd have to get on a rotation that if we don't use it, one of us supervisors just runs it up
Gotcha.
there, period.
Yeah, that would
Yeah.
make sense too.
So we're doing the Narcan distribution already. We're trying to partner for a MAT. It's medicated, what is it, medicated assisted?
Medication
assisted treatment.
This is my specialty now,
So
baby.
that's the
Buprenorphine.
I can't say it.
Yeah,
Buprenorphine.
buprenorphine and Sublocade, which Sublocade is the injectable version. Those are for opiates, and then most MAT programs also offer Vivitrol and naltrexone, which are for alcohol and opiates. And then there's also one called like a Camprosate, which is an old one that doesn't get used as much for alcohol.
Okay. So through the Narcan program that we're doing, they offer a MAP partnership, but our medical director was kind of reluctant when we first brought it up. But we want to kind of reopen that because we're seeing a lot of success with some of these drugs for opioid users. So we'd like to look at that partnership.
Sublocade is really, really cool too, I'm noticing, because it's in the same zone as buprenorphine, where it really doesn't have many, like Vivitrol, you have to take a certain assessment every couple months because there are risks of becoming more depressed or suicidal ideations or things like that. But Sublocade is just in the same zone as Suboxone, where it's not really giving anybody these weird side effects, and it's a shot that, depending on your personal needs, it can go anywhere between a week and a month. And so you could have you'll have to go once a month. Remember, once a month to not have opiate withdrawals or opiate cravings. And so it's kind of seeming to be one. It's expensive though. It's like $8 or $12 or $1,400 a shot.
Jeez.
Yeah, and so it's like, that's one of the big issues right now is the price, but it's looking really good.
Suboxone was the one I was thinking of, because the jail offers a Suboxone program.
And Suboxone is the strips, so it's easier to
Yep.
just give out like a 3-day, like you can arguably give out like a crisis prescription.
And I think that's more how this is.
It will be, it's also the buprenorphine is also, we have a meeting next Tuesday on that, next Wednesday, I believe, Tuesday or Wednesday, to get some more information about it. But this is gonna be post overdose,
Mhm.
that you would do that, so that they're less likely to.
I've been seeing a lot about that. I've read a couple articles about post Narcan administration Suboxone.
That's what this program will be.
Yeah, that's really
It
cool.
won't be until we can get the community paramedic program up and running
Right.
to where we could do more of a developed MAT program.
Mhm.
But this will be if we go out on an overdose, someone gives out Narcan or gives a patient Narcan, we can replenish that Narcan with our program that we have existing. And then we could also, with this program, give them the buprenorphine, and then that will decrease the withdrawal effects, so they don't want to have to go out and do it right away again.
One of the big barriers I've been seeing, because I'm over at Health Solutions now, and that's like what we do all the time, every day. But one of the things I've been seeing that's a big barrier that we might specifically run into more often is, I don't know if it's a DEA regulation or not, but they're unable to do anything with anybody that doesn't have a photo ID. And so I don't know if it's the DEA requires there be a photo ID to be able to like prescribe it like that. So that may be something we want to look into to try and figure out, can we, and on the flip side, is there a way we can give someone some kind of, government, like something that is acceptable for a form of identification? Can we prove it in any way as a government entity?
I'll bring it up in the meeting so
Yeah.
I can see.
That's just something
I haven't
I've
heard
been-
that was a requirement, but
Yeah, that's one of the barriers to care I've been noticing since I've been at Health Solutions, and it's something that they seem to just be hamstrung about. And so I have no idea if it's because of the DEA and the prescriber's licenses or what. But I know that we require very, very clearly, you either have to have a photo ID or you have to have the stuff that you would use to go get a photo ID. So it's like
Every time.
Yeah. Yeah.
Nope, I'm off shift.
No, but it's you.
Did you just quit right now?
No, I'm off today. I just
Oh,
came
I
in
see.
for the meeting.
She's the cloud.
Yeah.
Someone has to do it.
And a couple other programs we do. So we do EMS education. We do that once a month with the QRTs. We hold an annual BLS refresher. And then we've always got ongoing EMS education classes. We provide Stop the Bleed. We provided 100 Stop the Bleed kits to area schools that we got on a grant.
That's the one that I usually, like, when you guys will be up at the high school, college
Yep.
area.
So we got those on a grant, and we agreed that we would replace anything that expires in those every couple of years. We provide CPR and first aid. We provide initial EMR education and certification in the high schools. We might have to put that on hold because our EMR educator just retired. But we've done that for the last probably 7 or 8 years. We started with Trinidad High, and we've gone through different high schools. The last several years have been at Honey High School because they've been the most consistent. And we've actually hired 3 EMTs out of that EMR class, so it's been beneficial.
That's really cool.
And then we're looking to do a little bit more public health outreach. So our staff goes to the senior center once a week or once every couple weeks.
Every 2 weeks.
Every 2 weeks. They go to the farmer's market, do vitals checks. We try and go sit out at Big R or Safeway or Walmart every so often, do vitals checks. So we're trying to be out in the public a little bit more. Our current focus areas are recruitment and retention. Everybody's having this issue now. Retention we do pretty good with. It's getting people here. We've learned that we have to grow our own people because nobody wants to stay here because there's nothing here. So unless you're from this community, you're more than likely gonna leave after a couple of years. We're looking to improve interfacility transport safety and sustainability, long-term financial planning, expanding and starting our MIHCP program. And we've been involved at the state level. We want to continue that with the advocacy.
What was the person's name that we were contracting with, now that I know people at Health Solutions?
I don't remember. It was just one other outreach people
Yeah.
is who I was talking to. I don't remember.
Because I know they have like in Pueblo, I don't know if they have it down here, but they have like the MEIS team, I think they call it. I forget what it stands for, but it's like MIES. And it's basically the same thing. In Pueblo, they have an EMT, a behavioral health person, and a sheriff's office.
Oh, like the
deputy.
co-responder program that
Yeah.
the city has.
Yeah,
What
they
is
all
that?
respond in a van.
MIHCP.
That was a couple slides back.
Yeah,
It
it's
was
Mobile Innovative Health Community Paramedic.
Got it.
What focus are you guys doing on the interfacility transport and safety?
So that's part of the interfacility task force that we're on, and that's in some slides later on.
Okay.
Kind of what we're focusing on and working on.
Okay.
Just our EMS cost and unit hour analysis. So the unit hour analysis is kind of what private agencies do. We don't really follow it a whole lot here, but it kind of opens your eyes to the cost of readiness for a small agency like us. So 1 unit hour equals 1 staffed ambulance for 1 hour. So the benchmarks, 0.45 to 0.55 is the optimal. That's what we want to be, and that's on the high end. So these are the benchmark categories. 0.01 core utilization. Like I said, 0.55 is optimal, and then everything. So our total unit hours per week are 336. That's 2 ALS units staffed 24/7. Our annual unit hours are 17,520 hours. And this is based off of last year's totals. Our total calls for last year were 2,413, which comes out to about 46 calls per week. So to get our unit hour utilization, you take that divided by the 336 and you come out with the 0.14. So we're at the poor utilization end. So we're at the very bottom. So if we were a private company like in Pueblo and we were doing street corner staffing, I would drop an ambulance because we're losing money. Like I said, we can't do that here. It doesn't make sense for us to do that. This just kind of shows where we're
It's
at.
too many miles to try and do that.
So using our total budget for this year, $2,947,873, it comes out to $56,690 per week. And our cost per unit hour is $168.72. Regardless of whether we're running calls or not, that's what it costs us to staff an ambulance for an hour, or 2 ambulances for an hour. It's $168.72. Cost per 24-hour shift is $4,049.28. Our calls per shift is about 3.36. So that comes out to an average per truck of 3.36. So every day we're averaging about 6 calls, roughly. Our cost per call is $1,205.14. And then if you add in the operational costs, wear and tear, that kind of stuff, our cost per call comes out to about $1,222. So that's what we should be collecting on every call, regardless of whether we transport or not. That's for standbys, that's for cancellations. For us to break even, that's what we need to be collecting.
Which I'd like to point out, just in case you're not familiar, that EMS is it's absolutely never a breaking even game.
No.
Not even for private companies.
So this is our operational financial performance. So if you take our total budget, the operations side of the enterprise, plus the enterprise, you take our calls, we're using last year's calls because I don't know what we're gonna run this year. You take our average reimbursement from last year which was $448 per call. That leaves us with a gap of $774 per call. So that's what we're losing on every call. And then with the adjusted cost, and then I added in depreciation on this one, brings our per call number to $1,430, leaving us a $982 gap. So it just goes to show that EMS is not cheap and you're paying for readiness. Our interfacility transports, this year's. This year, so far we have done 152 interfacility transports as of May 31st. Our gross charges have been $917,000 roughly.
Is that just for the transfers or is that
This
in
is
total?
specifically for interfacility transfers only. So our gross charges were $917,863.30. Our contractuals are just shy of $275,000.
What's the contractuals?
The contractuals are what is taken off the top automatically. We have no say in it. It's what the federal government says Medicare and stuff can take off.
Okay. Okay.
Which leaves us with a net charge of $643,007. Our payments collected to date are $95,778.55. Our net charge per trip is $4,230, and our cash that we're collecting per trip is $630. So if you if you look at the 1222 that we should be collecting per call, we're only collecting about half.
I'll
of that.
never forget when Joe started here and he looked at this and he was like, you can't run a business like this. You can't write off all that money.
Yeah, if you
I'll
look at
never
the net
forget
charge
that.
per trip
Your
versus
job
what
was
we're
down
collecting,
here.
we're shy about
What'd you suck me into?
$3,800, $3,700. And then our net collections for intercity transports are only just under 15%. So that's losing money just all the way around. And this is just a breakdown of just the interfacility specifically. So take the cost per call. The total number of transfers we've done so far comes out to $185,744. At the revenue that we've collected at $95,778.55, we're looking at a loss of about $89,965.45 on just interfacility transfers. That's the loss of about 48.45%.
No, it's working fine. That's the sound that's happening.
Right.
Seems like they got closer to us too.
Yeah, they definitely did.
I don't know what to do.
It's fine, just X out. Yeah. You can't minimize it. You just have to pop mine back up.
It's great. Thank you. Technical difficulty.
So we're right about 50% loss for interfacilities so far this year. Our revenue sources are property tax, billing collections, some grants. We don't have any subsidies, and really the only grants we get are the RETAC, which is automatic, and that's $15,000 every year. And part of that has to go to Kim, so we always get that entire $15,000. So we use that to pay for our medical director, and he covers both us and Kim. And then, yeah.
What is the property revenue down as was predicted?
It is. It's down because of the property tax stuff. We lost about $300,000.
Right.
Yeah, that was what was on the last.
So it was about
budget.
1.2 and now it's 900 something?
No, we're still at 1.1, I think 1.1 or so.
Okay.
We're still over $1 million.
Okay.
Yeah.
Is it projected to go down?
We're guessing that it'll probably go down more.
Okay.
I don't know how much. We won't know until we're closer towards the end of the year. but it is projected to go down a little bit more because of the property tax cuts.
I haven't been in all the meetings, but I know Jody Amato has spoken about it. Maybe it's a conversation we have with her too, just to see what's coming. So I know they talk about it at the county commission meetings.
Yeah.
I think a lot of the property assessments have increased.
Yeah.
So there may be a pretty decent offset there.
Yeah, I know ours increased quite a bit.
And that saved
Like a
us
year
this
ago.
last time was
Yeah.
they did increase. So that did save us, but
I have a property, 1 acre, $10,000.
Oh, yeah,
I'm like, wow.
They started counting accessory dwellings. Our garage is now a countable square footage, and we went from like 2,000 to 23 or something like that, and it's, I mean, a lot more expensive between
Yep.
the rates, yeah.
Well, I don't want to, but I'm going to turn 65 soon, and there's a discount.
Yeah. Hey!
Jody said, be in within 6 months after you turn 65. It's like, I will be there the next day.
Yeah, yeah, can I show up 6 a.m.?
Yeah.
I was born at 10.
the other state grant that we get is the trauma grant, and every year we apply for something. Last year we got monitors on it. This year we applied for a couple oxygen concentrators and a piccolo device, which is for taking blood and doing blood samples on scene for our community paramedic program. We get some coverage fees from standby. We don't do a whole lot of standbys. And the football standbys that we do, we let the quick response teams handle those, and that money goes back to the fire districts. So we don't get any money from that. We get a little bit of money from the rad race, and I think there's a bike
festival.
race.
Is it festival?
The motocross.
Oh yeah, the caveman. So we don't do a lot of standby events. We don't get a whole lot of money from that. So here's our reimbursement challenges. So Medicare, Medicaid underpay. I mean, everybody knows that. Our private pay and high deductible plans create the bad debt. Contractual write-offs, like we just talked about, reduce the gross income by 35 to 45%.
Try clicking continue.
Our average collections per call about $448, with a cost between $12.22 and $14.30. I don't see a need for an updated billing policy. We do need the rate advocacy, which we started at the state level, and I'll talk about that a little bit more later on. And then the one big beautiful bill is gonna substantially cut. It's gonna change Medicare and cut Medicaid. And so that's probably gonna hurt us a little bit.
Yeah, a lot of the fees and a lot of the ways that the things are calculated are literally going to be calculated by multiplying them by 0 instead of a number. And so we'll stop, there's a lot of things we'll stop receiving stuff for.
So just some highlights of the one big beautiful bill that they're trying to pass. So it cuts Medicaid reimbursement. It provides tighter rules on the provider taxes. Colorado hospitals participate in that. Ground ambulance agencies do not, but it will still affect us because I believe that hospitals will want to transport those patients out more often because they're not getting the subsidies on them. And so I think you're going to see a lot more hospitals trying to move those patients because of the tax cuts. It's going to increase federal audits of the supplemental cost reports. So that supplemental cost report that I do every year that we get between $170,000 and $300,000 back on, that's going to go and or away. I think this last year, what I say, we got 160 or 170. That'll probably go down, and it'll just continue to dwindle until it goes away. Elimination of retroactive Medicaid coverage. So right now, today, if we transported somebody to the hospital and they don't have coverage, we can have them go to Medicaid and they can get put on Medicaid retroactively, and then we can bill them and they don't have to pay that. That's gonna go away. And then stricter Medicaid eligibility, so less people are gonna be able to get on Medicaid. So this is gonna be a huge revenue loss for us. Medicaid's a top payer for EMS. It's about 25% roughly of our paramedics. Provider taxes could block the state from using the supplemental EMS funding, which I just talked about. And the Office of the Inspector General audits are they could trigger repayments. So those supplemental funds that we received, if for some reason they find that there was something misreported, we might have to pay some of that back, which I don't see, because ours is pretty straightforward because we're just EMS. They're more looking at the fire-based EMS systems where they're not splitting that cost down the middle, or not down the middle, but they're not splitting that cost in the EMS and fire. They're combining some of those, and so some of those are going to have to be repaid back. And so it's going to have an effect on the smaller rural EMS agencies, as usual. It's going to increase operational costs in risk cutbacks, closures, and staff loss. Our current landscape, so I talked about the hospital provider fee. So right now, Colorado has a hospital provider fee that they're able to draw down federal Medicaid matching funds and therefore making more money on the Medicaid funds, and that's going to go away. So they're not going to see the benefit of that, keeping those Medicaid patients anymore. The state plan amendment, I don't know what SPA is, but it allows public EMS agencies to recover uncompensated costs and provide supplemental Medicaid payments to government-run EMS based. And again, that's more likely going to go away if they pass this bill.
SBA state plan amendment.
Thank you.
You told me.
I have so many things going on in my head. And then Medicaid covers the secure transport. That took Thank you. That took effect July of 23, and so it just depends on how they shape that Medicaid, whether that cuts those out or not. Right now, it reimburses behavioral health transport without prior authorization, so we'll see if that happens.
Dave, I need to interrupt for just a second. I need to hop off this meeting for a little while, and if it's okay, I'll call back in about 10, 15 minutes.
Okay.
Okay.
So the big beautiful spending bill is HR 1. And so the risks proposed under this bill, it's going to limit provider taxes, the Colorado Hospital Program. It's going to trigger the audits for the supplemental programs, and it's going to reduce Medicaid enrollment. Colorado, because we're already at $1 billion budget deficit, they were already looking at Medicaid funding because we pay, I can't remember the numbers, but we were collecting like 60 or 70% of our Medicaid funding was coming from the federal government that we were paying out. It was something crazy, whereas most states are under 50%. And so they're thinking that Colorado is going to take the biggest Medicaid hit when all this comes down.
And that was one of the reasons they were going after, was the few states that were double dipping basically off of the Medicaid funds. So.
Again, I'm just kind of reiterating all the stuff that I've talked about. It's gonna hurt.
Okay, I'm sorry, can you go back? What I was reading.
Oh, sorry. I didn't want to read through all of it because it's mostly just me repeating myself. Everything it's doing at the federal level, it's going to do to us tenfold.
There's really nothing though at the state level that they can do that's going to affect.
Well,
It's going to affect the state
you mean
level.
What's happening at the federal level, there's not going to be something backfilling from the state.
no,
No, because a lot of what's going away is stuff that the feds were backfilling.
For.
So
Since we're in a deficit anyway, they're not
Yeah,
certainly
so
not going to.
basically what the state's doing is just funneling that federal money straight down to us. And so when that goes away, there's not any kind of backfill, and we're already at that budget deficit, so it's gonna be even worse.
Yeah. So conclusion is. Thank you.
And we're not reliant on that supplemental program, it just, it benefits us, it's nice to get that little bit extra, but, I mean, that going away is not gonna make or break us. I'm more concerned with the federal funds from Medicaid coming into the state,
Yeah, like the actual payments we're gonna end up receiving,
or not receiving.
or not, yeah.
We've already discussed call volume at length and cost. So we have a mix of ALS, BLS, interfacility refusals, and standbys. Our 3-year trend is relatively flat with an uptick in MIH demand. So we've been tracking the patients that we think would benefit from mobile integrated health and community paramedic. And it looks like the need, well, we know the need is there. The hospital and the health department community needs assessment showed that it's there. Our community needs assessment showed that the need is there. So the 911 EMS everyday call is flat, seeing the need for the MIH. And that's a trend nationwide. And that's something that it's just gonna be something that happens across the nation here in the next 5 years, probably less.
Yeah, like I've said before, that this was a huge thing that Grady, which is the second busiest ambulance service in the country, that's a huge thing that they were pushing for when I was on the ambulance in like 2016 to 2018 time. And it was, because it's really the way to go. And it's like we're seeing the uptick in need because we're finally learning what, like, a different way to fill that void,
Right.
I think.
And then just the geographic concentration. Most of our population is in the 81082 zip code, 90%. So that's where most of our calls come from.
What other zip code?
There's like 7.
Really?
Yeah. So each little, yeah.
Regular.
Each little community that has a post office has their own zip code.
Got you. Okay.
So for each fire district we have, that's a community. We already talked about this. Our challenges, overtime fatigue, long transports. We have a need for preventative burnout and MIH. And all of this did not include the on-call costs of readiness. So I left all that out of the numbers that I already reported, so. Recommendations, adjust billing rates to our cost per call, which it's already above that. Our current rates for an ALS non-emergency are $2,000 base, and for a BLS non-emergency are $1,300 base. So we're already there, and it's been at that level since 2020, I think.
2021, yeah,
2020.
So, and we're the highest in the state for, I think, BLS, or one of the highest in the state. So to adjust those billing rates higher doesn't make any sense to me, and it's not fair because it just gets passed on to the patients.
Exactly.
So I don't see a need for that. What we need to do is make EMS an essential service and find a different funding mechanism. Again, aggressively pursue grants, which we've done. We went after AFG this year, the Assistance to Firefighter Grant. We get the RETAC grant automatically every year. I've been looking at other grants, and then we apply for the state grant every year. So we'll just continue to keep doing those and offset some of our costs. The state grant is a 50-50 match, so we're putting money into that. RETAC we get automatically. We have to spend the amount, and then we get reimbursed the full amount. AFG was, I think, 5% match, so.
So, I know you have the per call costs, and you're looking at calls versus per calls, each call versus like your actual expenses. I think what skews it is the ambulance service has a tax revenue that comes in, and I mean that largely supports the district. If it was a private, yeah, I agree. Then it would probably be really critical that We make sure everything is, the rates are at the very max and what have you, but there's that tax that comes in that helps support this district and helps support that on-call availability. That's where I see the biggest difference. And I get that there's always going to be things that where we're going to all worry about our budgets and what have you. But I think it's a little skewed because of that. You're not a private entity. You're a government basically, and you have tax funds.
So just the tax income that we get doesn't even account for our payroll for a year.
So explain, okay, so what am I missing in the budgets then? Because it doesn't look that way to me.
I'd have to look at it, but our budget for payroll, I believe, is $1.2 million
Okay.
for this year.
Mm-hmm.
And we just discussed that we get $1.1 million in tax revenue, if we get all the tax revenue. So that doesn't cover that. We're $100,000 short there, and that's not counting readiness for equipment, everything else that we have to do. Once again, as Gabe showed multiple times, with us only getting, so we only have two ways of making money. We have the tax revenue that doesn't cover all of payroll, and then we have the fee for service that we are at a deficit of anywhere from $700 to $900 per call. Now, realize, as Chief said, that's per call. That's not per transport. We're only getting paid for transporting people. So for all the calls, so out of last year, the 2,400 calls, 360 was interfacility transports, so they were transports. Then we had, so then you're down to 2,100, and then so there was only 16, roughly 15 to 1,600 of those calls that were transports. So that's another 600 or 700 calls that got $0.
Okay.
Does that make? Does
Yeah,
that help?
it's making sense. Yeah, that makes a little bit of sense, but it raises some more questions for me still.
So I don't know if this maybe would add into information as well. So we're predicted to get $1.1 million in property taxes. Not everybody pays their property taxes. Not everybody pays them in that year, and they're stretched out for 10 years. So even though it's said that this is what we're allotted,
Right.
we don't get it every year too. So that's
I'm glad you brought that up because Ogris has, and I haven't checked with Jody in quite a while, but Ogris, last time I checked with her, I think was in 2022, they owed us $300,000 still. And they haven't paid on top of their still continuing operations, so.
that's just one entity.
Yeah, so there's a lot of money out there.
So there's a lot of that
Right.
goes into it too.
And I'd asked this before, but then inevitably, as you go down the road, we would be looking at our demise.
Well, that's
Potentially.
one thing we're looking at with the secure transport. That's another revenue expanding venture, right? So we're
Right.
doing that. We've started that. The other thing is MIH. Right now, there's legislation that is moving forward at the federal level to start paying for treatment in place. They call it TIP at the Medicare level, which that is the MIH program. Remember, we're a transporting benefit. That's all we get paid for is transport. No matter what we do on scene, if we don't transport, we don't get paid. So with that, that's another reason that we are dedicated at the state level, at the advocacy level, to help this balance billing stuff and stuff like that, which our governor, it passed 100% through both houses, no votes, and he vetoed it anyway. So that would have made the insurance companies pay their fair share. That would have helped us a ton. It's just reality. So that's another reason that we're looking at the MIH program. Not only for, the big reason is it's going to help our community. We're going to bring services to this community that they've never seen, for one thing, and get health care out there. The other reason is we're going to be able to start billing for that as well once that gets passed through the federal level. we have to think outside the box to bring all this stuff forward,
Yeah.
so we're not looking at our demise.
And
in several
again, the
years.
flip side to me is still, I come from the world of private services, and it is not what we want. It's not it's not built of our community. It's a company that will take their resources and leave in a day's notice. There's nothing that requires them to stay. There's nothing that contractually obligates them. They may have to pay a couple $1,000s and they leave. And then a whole city, a whole county has no ambulances, has no response. And so we have to prevent that.
And
That's what happened all across the board in Georgia, and it's constant that your response times are terrible. What they do is they'll have two adjoining counties, so likely it would be like AMR that would bid, and they would have two adjoining counties, and then when Pueblo County or Huerfano County starts to get backed up and they have a couple extra calls, they'll send all the Trinidad people up there, and then you wait for 45 minutes or an hour to even get an ambulance on the way. And the private services are not good because they are really trying to constantly make profit off of a system that is not designed to make profit. It's designed to help people. And so private services just become a mess, and that's the only alternative.
So real quick, this went a little bit longer than I expected, and I want to go through a couple things real quick. So I'm going to skip this. I just want to show. So for every $1 property tax, we're providing 24/7 ALS local response. So at a call volume of $2,413, let me see, let me get to where I'm trying to get to. So our return on
There you
investment,
go.
so we're taking the 3 million, which is the total value of EMS delivered. It was $3,449,590. We want to divide that by the property tax revenue, which is $1,061,197. So it's not even 1.1. It comes out to about $3.25. So for every dollar in property tax that we receive, we are delivering $3.25 in EMS care.
That was confusing for me.
So on a a household that costs $250,000 a home, we're receiving about $48 annually
From that resident, or from that
from
property.
that property. That's what we receive in property tax. So we're not collecting a whole lot of money in property tax, even though $1 million sounds like a lot.
I don't think it sounds like a lot. I'm just saying it's a factor in that whole equation.
No, I'm not saying that you are. I'm just putting it out there because people say, well, you get all this money from property tax. It's not a lot. And so that's less than $1 a week for 24/7 ALS coverage, which I think is phenomenal for what we provide. And it's equivalent to a lot of places that do subscription plans. So there's a lot of places that they do a subscription plan that if you pay $100 a year, then EMS doesn't bill you. They bill the insurance, and then you don't get a balance bill at all. And that $100, which would be more than the 48 that we're getting, provides instead of that property tax.
Just to reiterate something too, kind of quickly in this conversation where you were talking about private companies coming in and being able to pull out just like that, and Tom's concern about the demise, which isn't, we're not gonna let that happen in this community, but to remember that emergency medical services is not considered essential anywhere. So
Nobody has
if
to have
it goes away, there is no obligation for anybody to provide that service. The city has no obligation, the county has no obligation, the state has no obligation.
Most likely what would actually happen, I say AMR would come down, but AMR doesn't
They don't
really
wanna
want to
come
be
down
down here. We've already had different conversations that have led us to believe that in the first place. And so likely what would happen is we'd end up with nothing. We'd end up with no ambulance service, and maybe the fire department would try to pick it up, maybe. But that's a huge, I mean, you see our expenditures, so we'd probably just end up with nothing, and we'd scramble and hope. And
I
try
just
and
wanted
find some-
to clarify the non-essential service.
No, for sure. It's a gravity that I think that is lost upon many very intelligent people, because our society does not really put that out there. That the way that a fire department or a police department has to exist, we do not. EMS just does not. And so the flip side to me is terrifying.
I can, it seems like yesterday to me, but when I started doing filming stuff 20 years ago, and I have the financial statements of the ambulance district, we're a lot healthier now than we were then. And I think what you've done here should either be put it on the website.
Yeah,
If you can send me a file, I can turn it into a video.
Yeah.
I mean, this is, very revealing and helpful to let people know, and that's the transparency that we want. We want
Yeah,
people
for
to
sure.
understand
Absolutely.
what our situation is.
Yep.
So if you'd email it to me, and can we put this on our website?
Yeah, how do you
I
feel?
don't know how we do that
Yeah,
with the
I wouldn't
ADAs
mind
now.
doing it. I don't know if you would put it all on there. Maybe find out what you want on there. Maybe
I would do the whole thing if you can,
Think so?
and I
You
can
can-
turn
yeah,
it into a video.
Yeah, I know you, like,
I-
Zeta does that.
Yeah.
You just
Because
turn it into a
people
video
ask
and
these
then
questions.
it's
This is
full.
where the community's like, well, do you know that they did this? And it's like with city council and stuff, until we filmed and people watched, they're like, and then the rumors ran rampant and none of it was true. I mean, this is very transparent.
Well, like last year, we had a $300,000 deficit, and we sat down for hours, pounding out how we make those numbers work, and it's by hook or by crook. We
did it.
Pull
Yeah.
it off, but, on paper, it works, so hopefully if everything happens the way we planned it, it works, but if it doesn't, then.
I'm sorry, Roger, I got a lot more, but I know you had questions and I didn't expect it to go this long, so
Yeah.
if you want to just ask your questions, or if you want me to continue, it's up to you guys.
I don't want to come across negative. I would rather have a private conversation with you after about just some of my perceptions.
And that's fine. I don't see you as negative. I mean,
No, but I don't want to come across as negative.
But I get that in the public all the time. You get $1 million for the thing, and I sit down with just
So
like you and
I'm going to
say.
say what I have on my mind then.
Yeah, I
If you
appreciate
want EMS to be a required service like police and fire, you've got to perform that way. Police and fire they can't say we're not going on this call because of fatigue. They don't have that option. They use their on-call and they do what they have to do. So if you're advocating for that, for it to be an essential service, you've got to do that. You've got to figure out how you address that so that these transfers happen when they should. I went back and read 3 years worth of minutes. I noted every time that transfers didn't happen. I'm not even sure that it really captures the whole picture, because I'm aware of other scenarios where maybe it happened 8 hours later or a few hours later. And those are the things that I think need to be addressed. I get the money. I totally get the money. But at the same time, if you have on-call services, those transports should be happening. Some of what I took away from the conversation is, and I got confused with the transfers versus interfacility transfers. So transfers from, say, my house to the hospital, you're going to get a check for that. Transfers from the hospital to Pueblo, maybe you will, maybe you won't. Is that okay? So my perception of that is that takes a back seat in the district's mind, because maybe you're going to get paid and maybe you're not.
Oh, no, we
That is never- that is never
I'm not saying that's what it is. I'm saying that's a perception, though. Because whenever you put somebody off and say, we're not going to transfer because of this, or this, the question has to be raised. If our focus is so much about money, does this boil down to money? I don't believe it does. I know you're all taking oath to save lives, but let's make it that then. Let's make sure you're interested in protecting people in their homes. That's great too. I think that's great, but let's make sure those transports happen.
so so out of Senate Bill 225, which was the Sustainability Task Force, they created a subcommittee or a sub-task force, the Interfacility Transport Task Force. And the whole goal of this task force was to improve patient EMS provider safety during interfacility transfers. So Colorado sees a need and a risk to improve the safety. So the whole point of this was to develop tools and guidelines to reduce the transport risk. So they started looking at the data, and here's the representation. So it's not just EMS chief saying, yeah, this is a big deal. These are all the players that are involved in this task force saying, yeah, we see that this is an issue. So it's the State Emergency Medical Trauma Advisory Council. They have air transport, rural facility leadership, so a rural hospital, EMS, urban facility physician, rural trauma, statewide, so MSAC, the state EMS agency, our local RETACs, the Regional Emergency Trauma Advisory Councils, a rural facility physician, an urban facility leader, so a hospital leadership, and urban EMS. And what they found was there's a 25% increase in IFTs over the last 25 years. They've seen that there's a
25 or 5?
Sorry, 25% in the last 5 years. They've seen that there's pressure for agencies to accept IFTs regardless of risk. They've noticed there's safety concerns with fatigue, night driving, and long distances. It's straining the 911 systems due to non-emergent interfacilities, and there's a lack of clarity on provider liability and transport authority. So they don't know who is responsible for this transfer. We were always told that the facility is, because we're working off of that doctor's order. So if the doctor says this patient's going up there for such and such and they have to be on this, I cannot adjust that. The doctor is the one doing that. So to me, the liability falls on them. So the whole reason I bring this up is because there's a lot of agencies that are risking or taking risks that they shouldn't be taking. So in bad weather, if their crews are running calls all day long and then they're on the road at night. So, and it's not necessarily the provider, but most accidents happen between the hours of, I think it's 10 and 5 in the morning. That's other drivers are fatigued. Drunk drivers, that's when most drunk driving accidents happen. And the majority of these patients that are being transported in the middle of the night, they're not going to have any kind of procedure that night or even the next day in a lot of cases. And so we're just looking at not denying transfers, but postponing them until it's safer to do so. It doesn't make sense for us to get on the road in bad weather with 2 people in an aluminum box and get stuck on the side of the road or get in an accident and kill the crew and the patient for something that doesn't need to go right now when they can be managed at a hospital, whether they're critical access or not. And they've got respiratory techs, they've got x-ray, they've got not an unlimited amount of medications, but a large amount of medications. They've got doctors, they've got nurses, and all we're trying to do is reduce the risk. It doesn't benefit me any to say, no, we're not doing transfers. We want to do the transfers. We know that our patients need to get to a facility that can provide certain services. We're just trying to make it safer to do so, is what we're doing. We've never flat out denied a transfer. We have always asked to postpone transfers. If the hospital decides to call somebody else, that's on them.
And this was and still is a very big point for me. And you can ask them, I'm the one who made us start talking about the statistic of every single month. What did we refuse and why did we refuse it?
It's on this month.
It's on every single month's report because I also care about it. I don't want us to be refusing any kind of transport if we have any ability not to. And so I absolutely respect your feeling about it, and I don't want to
So then what I would say is that, in my mind, you're not making an on-the-spot judgment call when you have a policy in place that dictates hours.
We don't have a policy that
There's
dictates hours.
There's a policy in here that does talk
based
about
on
hours
report.
of transport, and so I disagree with that.
And I think the other thing is too, I think really important to bring up is we have been using the risk assessment tool that the state's talking about implementing, okay, across the state. This is a problem, and it's not just our problem. It's across the state, okay? The safety, because we can't go out and find a paramedic right now. Can't find one. So if we hurt 1 or 2, we can't find 1, we ain't gonna find 2. On top of that, I will tell you what they're coming up with this task force and the risk assessment tool that they're going to provide to the state for everybody to use is more strict than what we're using right now. because they see it's a problem. They see and they know, because they have the physicians that are at the hospitals receiving these people. I have a personal thing. My wife went up for a hot appy. Her appendix was about ready to burst. She got in an ambulance in Walsenburg, and she was transported at 10:30 at night. You know what time her surgery was? 1:30 the next day. So what we're saying and what Chief is saying, we're not turning down transports. We're doing it safely. Because I guarantee you, anybody in this room is going to be the last person that wants to sit there and watch one of our funerals.
I also don't think it makes us less of an essential service to care about the safety of our people.
I never said that.
That is what
It's
you,
the people and the patients you're
No.
caring about.
Can I?
Yes.
you're saying that's
It's the people and
you're
the
saying that's the
patients. If you're
perspective,
putting
but
me
you're supporting it.
You're putting me and my partner in an ambulance at 2:00 in the morning when we've ran 12 calls
What I'm
today.
saying is you have
It's
an
not safe
on-call,
for either one of
you
us.
have an on-call
But they're getting off a
Paramedic.
48-hour shift.
Do you want to,
off of a how many hour shift?
48 hours.
So maybe you need to look at your hours, the shifts that you're doing.
So, okay, so the safest shift out there, Audra, is a 12-hour shift.
Mhm.
Okay? Do you realize that if we went from a 48, 96-hour shift,
Which was the staff's choice.
Mhm, sure.
which if we did that and we went to 12-hour shifts, we would have to double our capacity of employees. Once again, we can't get them down here now, so we can't do that. It's not feasible. That's one of the things that's coming up in this IFT task force is these rural areas don't have overabundance of, even in Pueblo, of having extra people to do that. So all we're asking, we're not saying that we're not doing transfers. We are doing transfers, and I'll report that we did transfers and we're at 140 this year. As Chief said, 152 to his numbers. But at the same time, we're doing it safely, so at the end of the day, we come home. So-
does your
And I
numbers show
fully
how many
support
doubles?
that.
Fully
Support that. I'm not saying anybody should risk
You just,
anything.
but you did say that if we want to be an essential service, then we should risk it.
What I'm saying is
Because the police
you
do,
figure out how to staff
which they don't.
so that you can make those responses, those transfers. That's what I'm saying.
I might be able to just throw a bit of light.
And then we can stop the
Okay,
conversation.
okay. This is just a quick bit of light, because I hear this from patients as well. You're in an ambulance, and an ambulance doesn't necessarily mean an emergency. An ambulance can be a non-emergent transport from somebody's accident to the hospital, from their house to the hospital. We're getting them there, but it's not an emergency. It's a trauma level. Or they can be going with lights and sirens and everything. We got to get there, everybody get out of the way. An interfacility transfer is a non-emergent, no lights, no sirens, driving the speed limit, pulling over for traffic, doing whatever you have to do. If it was an emergency transport, they would go by helicopter or by plane. So when you kind of put it in that context, it might help a little bit to understand the safety issues that are involved with the ground transport, that it's not an emergency, that that person has to get there within the next 30, 40 minutes, because we can't get them there that fast anyway.
Yeah, part of it's the hospital too. We have a doctor who says, we have to transport now. Well, in reality, they don't. Bub and I went through the storm in November, as emergency manager, and the doctor called and said, we have to move somebody now. We couldn't, the roads were closed, snow. So we called the doctor, said that they really have to go now. Well, all of a sudden, well, you know, we can probably stabilize it for, what was it, 6 hours or something like that easily. Meanwhile, we got a hold of CDOT and some other firms, and CDOT plow, went, took them up to Pueblo and took them up there, and we worked it out. But originally it was they gotta go now, and that just wasn't realistic. They couldn't fly can do anything. There's no other way around it but to take them by ground. So the hospital has to work with us to make some of these emergencies, are they really an emergency? And if they are, absolutely fine. But if they're not, then we need to, have that flexibility to say, look, we can't move them right now, but we can in 2 hours, or we can in 4 hours. And magically, that's what happened with this facility. Well, I think we can stabilize him. When he realized the situation, we explained it to him. He got more realistic. At first, I'm the doctor, I know what's best for my patient, they have to go now. Well, stop. And we have to keep everybody safe.
So what I would say would help the perception is if there wasn't the hour thing out there, where we're not gonna do this between these hours, and it's more of a cooperative effort, where you're communicating and saying, look, do they have to be transferred? Because the message
that's what
that
we
gets
want.
relayed.
That's exactly what we want.
That's exactly what we're
Right.
trying to do, but we have no recourse from the hospital where they're willing to work with us. We've been begging, we've been asking in every way, will you please contract with us as the payer of
Never
last
refuse,
resort?
yeah.
And they will not do it.
So, and I don't want to talk about that subject now.
Do you know how
What I
many
just want to say is
people have gotten back before me that I've transported because it was an emergent and it had to go right now, and that patient followed me back with their family in their car because the hospital said you don't need to be here when I got him up to Colorado Springs? And see, that's what you're asking me to risk my life for patients that aren't going to be seen or do anything. When there is an emergent transfer, I am the first.
Yeah, an emergency is a different story.
Paramedic
Absolutely.
to step up
An emergency
and take them,
happens no matter
time
what.
of day.
And that's what police
I have
do.
put 2 patients in my rig and taken them at once so that they could both get to that definitive care that we need. We're not about putting them off and trying to harm people. We're here to help people, and I will help every single patient I can. But my safety should be a factor too. If that patient is stable and in a hospital, why is it an emergency if they're stable and they're not getting a procedure for 12 more hours?
Can we take it a step?
Yeah.
Because I feel like.
Bring us back to Senate.
Yeah, we're getting a little
Yeah.
emotional and
Yeah.
defensive.
Yeah.
And I
That's not
apologize.
trying to see what we're
I
doing.
also got emotional and I'm
It's a
sorry.
conversation.
But
well,
it's-
same. I'm not.
I do view it as a
I-
conversation. I don't view it as anything defensive or angry.
And same,
but-
I would not want anyone to risk their lives to do what boils down to a job, even if it's a job to save lives. It's not worth everybody getting killed because you're trying to save a life that maybe they're not going to make it anyhow if it's an emergency.
Right.
Who knows?
Right.
So it's not that, and I don't want it to be perceived that somehow, some way, the hospital has to know that there needs to be a conversation for the safety of your personnel, instead of a message carried to patients and their families that they're done at 2 o'clock, so you're going to have to wait.
So part of the problem is, well, do you want to go first?
Yeah, but, so, because there's probably nobody in the country, maybe a handful of people that have spent the last 20 years in as many government meetings as I have. And I think what's happening today is essential. The city has a meeting coming up to train board and commission people. And what we have, and I could go through the list of people I've watched in this room and the other building, how that changes. And one of the things that doesn't happen is that you bring people on and you kind of assume that they know. You guys live it every day. And so it might get a little frustrating, but after 20 years of watching this, just don't assume that we know what you guys know. And really the way government should work is you really need to train people, that are coming on and say, hey, to get them up to speed. And I think what happened here today.
No, I think that's why I value this a lot, and I'm sorry for getting as emotional as we all did, because I agree with you. I think this is a part of fully understanding the breadth of what's going on, how everybody feels, what the perception is, because it's a dire thing going on, and it's something that we are constantly trying to figure out how to fix and how to extend an olive branch and fix it. As this board is a very big proponent, and I can't speak for the previous ones, but this board is a huge proponent of, we're out here by ourselves as a medical community, and we have to work together.
Yeah.
We can't have a bunch of, for lack of better words, pissing competitions.
Or pointing fingers or
Exactly.
whatever, because
You're-
that's
exactly.
what it ends up being.
No, 100%.
And so just to clarify a little bit, so the times were put out there because the hospital was wanting us to go to Denver at 5 in the morning. Well, that's when we were doing 24/48s. And that's putting our staff on for 24 hours plus another. It takes about 7-hour turnaround to Denver, depending on where you're going, to get up there and back. And so we put those hours as a guideline to say that we want to keep our staff within their allotted shift so that they're not burned out, so we're not paying an exorbitant amount of overtime for a bunch of different factors. So that's the only reason those times are there. It's not to say that, oh, you're dying, it's 5 o'clock. You're gonna have to wait till 8.
And I talked to a doctor not long ago, and they have limitations too. So all of a sudden, the ambulance district's limitations, well, you shouldn't have any limitations. You should do what you're paid to do. Well, the hospital has limitations too, because they can't treat certain people past a certain expertise level. So they have to transport them. So it's like me going to the hospital and saying, well, you're here in the hospital, you have doctors, you should fix this. And demanding that they fix it there now when they don't have the tools.
Right.
Well, it's the same thing here. We have a limited amount of tools, and everybody has to start working together so that we can balance out the best of our ability those limitations. Because as you know, you can see the money's getting tighter and tighter and tighter. And it doesn't change the objective. The hospital still has limitations. We have limitations. And what happens is they say, well, you've got to supersede your limitations for our benefit.
I just have one last question, and then I promise I'll drop this subject.
I do think it's very healthy for
This is
us, I
good.
really
No,
do.
yes.
I
Yes.
genuinely appreciate
This is
us
great.
getting into hot topics because we then understand each other a lot better. And so I really do. Thank you all for going through it, but I do.
So, back to helicopter plane. Is there a certain criteria where they can only call that helicopter or plane? Or is it just, it's emergent, they've got to get there? And then they're gonna do that and save that little bit of time? Just explain that, because I don't know the answer to that
So
question.
there's what they call dock-to-dock time. So in an ambulance, it takes longer to transport by ground than it does by air, okay? So those more serious patients, your severe heart attacks, your severe strokes, your severe traumas, most of your severe hemorrhages, those type of things. Those are the type of things, we want to utilize the proper transportation mode for that, okay? For instance, Raton or Alamosa, they have even harder problems getting stuff, transports out of Raton and Alamosa.
Right.
So they fly a lot of patients. That's not good for patient advocacy because that costs the patients a lot more money. The idea is we only put the people that need to be on those helicopters and those are the sick of the sick. Those are the ones that need to have a procedure when they get up there. No different than the lady we flew out
2 days ago.
2 days ago
Right here.
from our parking lot. We were doing a Flight for Life standby.
They were here for
Happened to be
training.
one of our
And we had
one
to
of
run.
our
And they're like, bring her here.
paramedics' grandmothers had a big heart attack. We had a helicopter right here. Instead of going to this hospital, she needed to be in Pueblo. She got on the helicopter in our parking lot. She was there, and it saved her life.
Wow.
5:45.
Yeah, I know.
So,
Oh,
Okay,
sorry.
It helped a lot.
It's
Oh, I
bit
just-
by
I-
bit,
And
there's
I
a lot of
think-
pieces.
Well, and two, I think that the moral of the story is there needs to be a conversation with the hospital.
yes,
Yep.
I agree.
To change this perception.
Yes.
So we've had
We do
We-
that
we've-
damn
we've
all
had
the
those
time.
Why didn't you think of that?
Yeah,
So,
that's the look in his eyes, is Joe and I especially are like, do you think it's time? We want to have an olive branch, like, we want to do it again, can we do it
You have to do
again?
it again.
Yeah, I
We
agree.
have
I
had
agree.
those conversations, and Bubba attends the year trauma meeting every month.
Mhm.
And every time we go, we tell them, this is what we're doing, and this is why we're doing it. In the moment, they say, yeah, that makes sense, this is great. But when an emergency comes up, they just think it doesn't work, it doesn't make sense. So we've had those conversations, we continue to have them every month. So it is taking place.
But
I don't
do
know if that
think
gets
we-
relayed up higher, I don't
Yeah.
know,
But-
but.
I think it needs board to board. And
I do-
maybe
I
not
do
a
too.
quorum, but we select a couple board members and let's sit down, and I know them all, she knows them all, I don't know about you guys, but they're all friends of mine, or at least,
Acquaintances.
acquaintances,
Yeah.
and when this other stuff is done, in a small community like that, I can go back and relate a lot of other things where I tried to bring people together, and they just didn't want to do it because of the egos and the territory fights, and it's like, but we're so small, we need to sit together.
Absolutely. And in my heart of hearts, I believe that it's problems that are just continuing to fester beyond two old dudes that fought with each other from old problems. And we have issues that we absolutely need to fix that were brought to light out of it. And I think it's time for us to get back to working with the hospital as opposed to letting two guys that aren't even involved with us anymore control our futures. Because we have no reason to keep fighting. We're in the middle of nowhere, and we have nobody but each other. So
That's what I like
That's the
that.
key right there.
And I think the one thing, though, we have to keep in mind is the reason we're doing this, the state recognizes it, EMS recognizes it, is we're putting people at risk for non-risk decisions. And so as long as if you guys want to go as a board and do that, that's perfectly fine. But understand, it is a priority to make sure that not only our patients, but our people are safe.
Yep, absolutely.
At the end of the day.
And I think it's something it's growing pains, in my opinion, because I come from the time of we didn't do safety. They didn't care at all. And I've had partners that flipped ambulances from falling asleep. There was a firefighter in our district that killed himself because he fell asleep, he hit a teenager and killed her. And it's some of the worst things that can happen, and it's based on the safety that we didn't know was fully necessary until the past couple years. And so, yeah, I agree with you, and I also agree with you that I think it's going to take growing pains that we have to try and make safety paramount, while also getting with the hospital and explaining and showing, not even explaining, working together to show we don't have to fight. We don't have to do back and forth. We can be together.
And here's the scenario, I promise I will stop.
That's
Here's
okay.
the scenario that comes to mind. The hospital can say, we want to transfer you to Pueblo. They can spend hours trying to find a bed, and there's no beds. That is a lot more acceptable than for them to relay a message that, the time of day you're going to have to wait. That's where it's killing the district. It's hurting the district. But it's hurting you. It's hurting the reputation. It's tarnishing relationships, I guess, in a sense. People aren't going to have that same level of confidence, I guess, in the district if that's the message. And yet the scenarios are exactly the same. There's a delay, and in both instances, they have merit.
Personal experience.
Yep.
Husband's in the hospital, needs to be transferred. 6 hours later, the staff kept coming in. I'm sorry, the ambulance company had a 911. I'm sorry, the ambulance company had to go on an emergency. 6 hours to get that transfer. And that's not here.
Yeah.
So it happens
Everywhere.
everywhere.
Mhm.
It's not that nobody wants to do it, it's just,
Yeah, and I would hope that, I think a lot of, like what you've shown today especially, has shown we're not, while money is a very important part of what we have to deal with every single day, and we have to make sure that we don't bleed it out, it is not why we're here. We do not care about whether or not we get paid for a thing when it comes down to whether someone needs care.
Well, and that's the point, is we don't find out if a patient can pay before we
Exactly.
transport anyway.
no.
That's all after the fact. So
Right.
we go, we get a face sheet, and we transport.
Right.
We figure that out on the back end, so that's not a factor at all.
I just leave it at the last thing I'll say before I get corrected again. I don't know the exact numbers, but I bet you we're above 90% of every transport by ground that goes out of this hospital. Trinidad Ambulance is doing it. So all of this, what we spent and that we're really going on about, is such a minute number of incidents.
That's what I've learned by having the numbers in front of me each month, is like for most months it's one or none, and the one is at most typically a delay, and then the other ones have been like they wanted us to drop off a patient at their wheelchair in front of Safeway from the hospital, and we legally cannot do that.
Yeah.
And it's like, so that's basically what I've come down to after having all the numbers in front of me each month and having explanations as to why we didn't take this patient yeah.
Okay.
Good job,
That
team.
was long,
Whew.
but, I mean, I think it's cool to show.
Totally, and I think it's important. It's most things that are this important are also this not easy.
And I promise you, I have worked every schedule in my head to try and figure out something that would work. And I put 4 schedules out for the crews to pick from, and probably about 50% of them told me if we ever go to 12s, I will quit.
That's how I felt. When I was on the ambulance, you could not make me work a 12. The Kelly 12s, oh my God.
I don't
no
have
way.
an answer. I mean,
Yeah.
we can't get people, and I can't find a shift that will make people happy.
Well, but I guess at the end of the day, that's not the problem. It's,
Well, yes and no.
it's some of it, but it's the messaging more than anything.
I can 100% get on board with, we could use to reframe it in a way that is more, like with the way you compared it to the hospital being able to just be like, yeah, we don't have a bed, and it's
Exactly.
normal, it's commonplace. And ours, for some reason, sounds so stressful to people. And if we have a way of reframing it, it's still putting safety forward, it's still putting our people first, and it's trying to help it's helping the community hear it in a different way.
But is that our communication, or is that communication on the other side trying to make us look bad?
That's true. I agree, but
we've definitely
all we
seen
can do
that,
is
too.
control ourselves. All we can do is account for ourselves
And
and what we put
I'm not
out.
saying that's happening,
I
I'm just.
believe you.
It's
No, I fully believe you.
a valid question.
Absolutely, but it's one that we have no recourse on without meeting with them and squashing it. Without meeting with them and getting, I hope it will. That's all we can do is hope and try and move it
That'd be
forward.
nice if
And if
it
it
was.
doesn't, this is what I tell people about dating, where I'm like, you put yourself out there, you make it vulnerable, and if you get burned, that's on them. You put yourself out there and took the high road and tried. And that's what I think, yes, we have to be more careful because it's bureaucratic, it's business, it's legal, it's government, but that's still kind of at the core of what I think it is we have to try. And if they turn it down and they act poorly, that's their bad faith. That's not our bad faith. We tried and we'll try again. So,
I appreciate you, and I hope
I
you
agree
don't
with
feel
that.
attacked.
yeah, I hope you don't feel attacked either.
No, I don't. And I don't want you to feel like I'm being adversarial.
I don't. I think you brought
This
up a
helped me
Yeah.
quite a lot.
Yeah, and like I said, I think it's a very valuable part of us all understanding each other
Yep.
and where we're coming from on this. Because,
Nothing like a good education.
oh yeah, yeah,
Well, and I
good
will be
learning
the
moment.
first to be that advocate for this district
Yeah.
and talk to that board and say, look, you've got to change the narrative.
And I am happy to be there with you.
And you
Because
have to ask the hard questions.
Exactly.
I'm sorry,
I
you
agree.
can't just say, well, let's see if we can all just get along.
No.
No.
There's hard questions that need to be asked, and there's hard answers, and there's answers that aren't gonna be
It's
happy with.
like what just
But this is
happened
the
here.
best we can do with
That's
what we
right.
have. So,
But so, yeah, thank you for going through this. I appreciate you and I
Sorry
hope
for
you don't
dragging
feel.
it out.
No, it's okay. I think it's
It was
very
necessary.
important.
I
Yeah.
personally hate her.
Yeah. It's like I'm judging you right now.
Just get in line.
But thank you, seriously, thank you. I appreciate that we all give a shit. It's my normal crass style. Okay, so that will move us to the mirage of item number 5. We'll adjourn from our
I guess
work
we don't
session.
need to adjourn, do we?
No, we just conclude it.
Just,
Announce it's
just
Yeah, we'll
say it's
conclude it.
done, and we already,
Before we start, do we want
I
to
was
call,
gonna
what's her
call
name?
her back,
Yeah.
yeah,
Oh,
for the
yeah.
meeting.
And I need to grab some water.
Here, grab me some too. Oh my gosh. Is there vodka in that glass?
Yeah, you're all
That'll
saying
make
vodka.
me feel better.
Yeah.
Let me take it.
Yes.
Turn that off for a sec, and then we'll start again.
Yeah, give it a rest.
I'm gonna end this. That was the work session.